For 8 years, she was handed prescriptions for a mind that wasn't broken. The fatigue, the breathlessness, the heaviness in her chest, all attributed to depression. But her heart was quietly failing, and no one thought to listen to it. This is the story of a woman whose symptoms were real, whose suffering was documented, and whose diagnosis was delayed by nearly a decade. She lived with a label that explained some of what she felt, but obscured what was actually happening inside her body. The details of her personal life deserve protection, so we focus here on what the clinical picture revealed over time. She was a woman in her middle years, managing daily responsibilities while carrying an increasing weight of exhaustion that no amount of rest could relieve. She had no dramatic cardiac history in her family that might have raised early suspicion. She presented as someone struggling emotionally, and because depression can produce fatigue, low motivation, sleep disturbance, and even physical pain, the diagnosis seemed to fit. Her clinicians were not careless. They followed a reasonable interpretation of the evidence in front of them, but reasonable is not the same as correct. The timeline stretched across years of appointments, adjustments, and frustration. Early on, she reported persistent tiredness and a vague sense of something being wrong. Her mood was low, her energy spent. A diagnosis of depression was made, and antidepressant medication was prescribed. When the first medication didn't fully help, it was changed, then changed again. Over the course of several years, multiple antidepressants were tried, doses adjusted, therapy recommended. Some periods felt marginally better, others were worse. She reported difficulty climbing stairs, shortness of breath during mild exertion, and occasional swelling in her ankles. These symptoms were noted, but often interpreted through the lens of deconditioning, meaning the physical deterioration that can follow prolonged inactivity associated with depressive states. Year after year, the pattern repeated. She would present with worsening fatigue. Her medication would be reviewed. Sometimes a new approach was tried, but the underlying trajectory was one of slow decline. She gained weight, which was attributed partly to medication side effects and partly to reduced activity. Her breathlessness increased. Sleep became more disrupted, not from racing thoughts, but from a need to sit upright to breathe comfortably, a symptom called orthopnea. This particular detail is significant because orthopnea is a hallmark of heart failure, not depression. By the 7th and 8th years, her functional capacity had dropped considerably. Activities that once required only modest effort now left her gasping. The swelling in her lower legs had become persistent rather than occasional. She described a pressure in her chest that she could not quite articulate, different from sadness, more physical, more structural. Then came the moment that changed everything. During a routine visit, a clinician, possibly new to her case, noticed the ankle edema, the swelling caused by fluid retention, and the elevated jugular venous pressure visible at her neck. These are not signs of depression. They are signs of a heart struggling to pump blood effectively. A simple clinical examination raised a question that 8 years of psychiatric treatment had never asked. What if this isn't her mind? What if this is her heart? The investigation that followed was methodical. An echocardiogram, an ultrasound of the heart, revealed a significantly reduced ejection fraction. Ejection fraction measures how much blood the left ventricle pumps out with each beat. A healthy heart ejects roughly 55 to 70%. Hers was markedly below normal, indicating dilated cardiomyopathy, a condition where the heart muscle becomes stretched and weakened, unable to pump efficiently. Blood tests showed elevated levels of B-type natriuretic peptide, a hormone released when heart walls are under stress from volume overload. A chest X-ray revealed an enlarged cardiac silhouette and fluid in the lung bases. Every objective test pointed to chronic heart failure that had been progressing for years. The differential diagnosis at this stage included ischemic cardiomyopathy caused by blocked arteries, alcohol-related damage, viral myocarditis, or idiopathic dilated cardiomyopathy where no specific cause is identified. The mechanism in plain terms is this: her heart muscle had gradually weakened and stretched, making each beat less effective at circulating blood. Fluid backed up into her lungs and legs. Her organs received less oxygen. The result was crushing fatigue, breathlessness, and physical decline that mimicked and overlapped with depression. It is important to acknowledge the diagnostic difficulty here. Depression and heart failure share symptoms including fatigue, sleep disturbance, reduced activity, and cognitive slowing, sometimes called brain fog. Neither condition excludes the other. Many heart failure patients also have depression. The clinical challenge is recognizing when physical findings exceed what a psychiatric diagnosis can explain. Once identified, treatment shifted dramatically. Medications standard in heart failure management, including ACE inhibitors to reduce the workload on the heart, beta blockers to slow and strengthen the heartbeat, and diuretics to remove excess fluid, were introduced. Her breathing improved, the swelling reduced. Her energy, while not restored to what it once was, became measurably better than it had been in years. The heart muscle damage accumulated over 8 years, however, could not be fully reversed. Treatment could slow progression and manage symptoms, but the years of unrecognized decline had taken a structural toll. What does this case mean beyond one woman's experience? It illustrates a pattern recognized in medical literature called diagnostic overshadowing, where an existing diagnosis, particularly a psychiatric one, causes new or worsening physical symptoms to be attributed to the known condition rather than investigated independently. This is not unique to depression or heart failure. It can happen with any chronic label. The lesson is not that clinicians failed through negligence, but that diagnostic assumptions, once established, can persist longer than the evidence supports them. This case cannot tell us how common such misattribution is, and one patient's timeline should not be generalized to all patients with depression diagnoses. She began her story breathless and heavy, told it was the weight of her own sadness pulling her down. It was not sadness, it was fluid. It was a heart muscle slowly losing its ability to do the one thing it exists to do. 8 years is a long time to carry a wrong answer. This video is based on a publicly documented medical case and is intended for education and storytelling only. It is not medical advice. If you are experiencing concerning symptoms, consult a licensed medical professional. Medical mysteries. Every symptom has a story. Every patient deserves to be heard. Medical disclaimer. This video is based on real, publicly documented medical case reports and is intended for educational and storytelling purposes only. It is not medical advice. If you or someone you know is experiencing similar symptoms, please consult a licensed physician immediately.